access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference?
Good day, everyone. Welcome to our 5th webinar in the Cardiac Critical Care Fellowship. My name is 𝐏𝐔𝐙𝐙𝐋𝐄, the Director of Critical Care Fellowship Program, and I will be the host for the event. I wanted to extend a warm welcome and all thanks to all our panelists and attendants, and especially to our speaker today, Dr. Mazen Khairallah. This webinar holds a special place in my heart as presented by my mentor. I will leave the formal introduction to Dr. Ayman, because if I begin, I will never stop. Thank you for the panelist, Dr. Servasta, a critical care consultant, as well. He is an ECMO certified. Dr. Ayman, consultant in critical care medicine, who has a special interest in hemodynamic and has a subspecialty in geriatric. We are also joined by Dr. Ismail, a consultant cardiologist and our faculty member, one of the best speakers whom I have the honor to collaborate with. Just a few quick notes. This session is being recorded and will be available in our YouTube channel. Please feel free to post your question during the live discussion at the end. Again, we are thrilled to have you all, and I will give the mic to Dr. Servasta to introduce our first speaker. Thank you.
Thank you, ma'am. Thank you. Thank you, ma'am. Good evening, all. So it's my honor to introduce you to Dr. Abdullah Rahman Asri. He is a consultant in critical care and cardiac critical care, and he is an ECMO consultant as well. And he is working as an assistant professor at King Khalid University. And he is also the co-director of the online fellowship program, where he has played a pivotal role there. And this evening, Dr. Asri will provide us with an overview of the cardiac critical care online fellowship program, highlighting its vision, structure, and opportunities it offers for us for a professional development. Over to you, Dr. Abdullah Rahman.
Hi, thank you for the introduction, and hello, everyone. Thank you for joining us today. My name is Abdurrahman Asiri. I'm delighted to introduce you to the Cardiac Critical Care Fellowship. It's a unique, fully online learning opportunity aimed to advancing clinical excellence in the cardiac critical care patient. Why cardiac critical care is important? I think it's a rapidly evolving field that bridges the gaps between the cardiology and the cardiac surgery and the anesthesia and the management of complex multidisciplinary patient population. With the time and increasing the cases of advanced cardiac disease, there is real need for well-trained, highly skilled clinician who can deliver top quality evidence-based care, especially in settings where resources may be limited. And our fellowship program is specifically designed to address these challenges and help healthcare professionals like you gain to expertise necessary to make a difference. So our program is 1 year fully online fellowship its structure is both flexible and comprehensive, make it ideal for working professionals around the world. Also, the program is divided into 3 modules, each lasting 16 weeks, including the exam at the end of each. Also, the learning is delivered asynchronously. You can access high-quality audio and video lecture in your own schedule. Each module has a dedicated video lecture, a reflective practice, and international guideline and case discussion presented, real-world challenging cases and solution, MCQs with answer and detailed explanation for these cases. Also, the critical appraiser of up-to-date critical journal or articles with the peer-reviewed scientific publication. All activities, assignment are managed and monitored through our easy-to-use online platform. Also, one of our program hallmark is our truly international multidisciplinary faculty. You will learn from experts based in UK, Canada, and USA, Qatar, and Kuwait, KSA, Egypt, Europe, and Africa, and India. And they are, most of them, they are a teaching team bring together specialized in cardiac critical care, cardiology, and also electrophysiology. Also echocardiographer, cardiac anesthesia, cardiac surgeon, and advanced heart failure. And we also involve the perfusionist with the mechanical circulatory support specialized. The diversity ensure you will encounter a wide range of perspective and best practice in our fellowship. So the core objective and the feature of this fellowship is close the critical care gaps, especially in the environment within limited resources. Also enhance your knowledge from both medical and surgical viewpoint. Also train your to manage a special population complex case where proper intervention can dramatically improve the outcome. Also advance your skills in combining with the cutting edge technology and human expertise, particularly for mechanical circulatory support patient. And every week we have provide qualitative and quantitative assessment. Your engagement and activities are carefully monitored, ensuring truly interactive, accountable learning experience. You have seen here this WhatsApp group where we use it for daily tasks and discussion. We use critical care appraisal for 1 articles every week. Also 5 to 10 questions daily with discussion and explain why we think how to approach this patient. And this is the WhatsApp group scan or barcode if you were to involve in this group WhatsApp. As we mentioned before, the program modules, it's I will just briefly walk you through this module and learn about each module. The module 1 is Foundation of Cardiac Critical Care. You will gain solid grounding in the principle of cardiac critical care, from assessment to monitoring to evidence-based intervention. The module 2, you will have develop expertise in the pre-operative, intraoperative, and post-operative management for cardiac patient with case studies and decision-making scenarios. Also in the module 3, you will have mechanical circuitry support, and you learn how to manage and troubleshoot with these advanced technology therapies, including ECMO, pads, and other devices essential to modern cardiac critical care. Each module include interactive MCQs, case discussion, and critical literature appraisal. So for all the activities and the certification, when you complete all these programs, you will be, inshallah, successful of the CME certificated, accredited by American Accreditation Association. And you can also have, after you finish your program, you will be master the comprehensive management of critically ill patient. I think the program here next beginning, it will be in September. So there is a short time still to apply for this online fellowship. All learning is online and asynchrony, and you decide when and where to study. Doesn't need to take dedicated time to see the videos or to share with dedicated time. To learn more and begin your application, you can visit our website, and you are welcome to reach out for any question with Dr. Ashwa or any one of the board member to asking about the program. Thank you very much for your attention and interest and advancing your knowledge in cardiac critical care. And there is question or concern. Thank you.
Thank you, Dr. Abdurrahman. Inshallah, we'll bring all the questions, inshallah, at the end of the presentation. If you allow me now, it's an honor to present Dr. Mazen Khairallah. Dr. Mazen Khairallah, mashallah, one of the leaders in the critical care, and he has put a value in and he was the mentor for most of the fellows in Saudi Arabia and also now in Syria, and long time ago also in the United States of America. So Dr. Mazen graduated from University of Damascus, one of the elite university in Syria. Then he pursued his dream, and he followed with extensive training in internal medicine, followed by infectious disease, and at the end with the critical care from several well-known American institute, such as the well-known University of Illinois, University of Chicago, the Medical College of Wisconsin, and also Wayne State University. Since 2003, Dr. Khairallah has served as a consultant and medical director in the critical care of Sanford Health System and held a leadership role in Saudi Arabia, as most or some of you met him, and also in Syria. And now, mashallah, he's lending a hand in the post-Syria era to develop the critical care and the service there. He's also clinical associate professor in the University of North Dakota, recognized for his teaching and founding member and the past president of the Middle East Critical Care Assembly. In addition, he's the creator of the online learning platform ICU Reach, which helped a lot, including myself, and continue of our ICU study and ICU fellowship. He's well known in the research, focusing on the improvement of critical care quality and the safety. He has also expert in the computer programming and making the competition with him a little bit difficult, and the blockchain technology, including also founding of the online platform, which is take care of it until this moment. So without further ado, if we can welcome Dr. Mazen to start his, inshallah, it will be an amazing lecture. تفضل Dr. Mazen.
Bismillah ar-Rahman ar-Rahim. Thank you very much. Appreciate being here, and thank you for the introduction. I'm very pleased to see my colleagues, Dr. Ashwaq, Abdullah, Abdurrahman Asiri, Akhi Ayman, Barakallah fikum jami'an. So I'm not sure how difficult my job is going to be today. The goal is to make the assessment of hemodynamics an easy process. And of course, I have nothing to declare or claim in terms of conflict of interest. My intention is to simplify things in a way that we can assess patients in the intensive care unit with hemodynamic instability in a better way, using whatever resources we have, whether we are in limited resource setting or in fully equipped resource setting. And as you see, the name of the presentation is called hemodynamic puzzle, because it's usually, or most of the time, is puzzling. When you have undifferentiated shock, you would be asking the question, is this hypovolemic shock? Is this distributive shock, neurogenic shock, cardiogenic shock, obstructive shock, or is it combination of things? And usually have multiple tools, multiple methods to assess. However, we need to put these tools in a way that we can make sense. And probably most of us, when we get into our 80s, and I'm not sure how long I'm going to practice medicine, but my father is actually spending lots of time with these puzzles. And it's really killing some of his boring times and helping him to maintain some capacity in terms of cognitive functions. He's now 93 years old, 94 years old, I say. Alhamdulillah, God bless me with long life for my father, and I hope the same for you and your parents too. But when I presented this puzzle to him, the first question he asked me, where's the guide? He wants to know what is the full picture, so he can understand how he can assemble those pieces together. And this is very good, actually. We need to have that full picture in our mind. And once he's done, he can actually look at this very nice scenic view, and he's proud of what he's done. And this is actually what we want to achieve. And first, before we have some polls, if you're on your computer and you have your phone, please direct it to this barcode and try to answer the question and see how many of you would be able to contribute. And we have a total of 200 in this webinar, and I should say that this is probably the most attended webinars I've ever been in. So thank you very much for the organizing committee of this great platform, and I'm very pleased to contribute to this platform too. So as you see, I'm not sure, most of us actually 75%. I'm one of those guys who cannot actually function without coffee in the morning. But I found out that some people can actually do nothing. Here, 5%. They wake up and they don't drink anything in the morning. Juice maybe for our kids. That's the first thing they do, similar to milk. But majority of us, 70% here, and we have a total of 36 participants. So I hope that you continue contributing and participating in the polls that we're going to have. You will see that there are multiple questions, question number 1 and so forth. And this is the puzzle that you get presented with. And you have multiple pieces that do not make sense. And as I said, the first thing that you need to get presented with is what's a full picture. And this is the full picture here. This is what we're aiming to do. We need to apply this formula that is essential in terms of assessment, understanding, and management of patients with undifferentiated shock. And this is based on Ohm's law that can actually be applied in any circuit. And here we're talking about a circuit that starts with the arterial side and goes all the way to the venous side back to the heart. And the difference in the pressures between the arterial side and the venous side should equal the flow multiplied by the resistance. And the flow is the cardiac output, and that is stroke volume multiplied by the heart rate. And then you multiply this by the resistance. So this is the full picture. And if I go back to the pieces that I have, when you flip them back, you will see the front face of those pieces. And you can see here that they have different colors. And this is what my father would do actually. First thing is like, he tries to arrange the ones that have similar colors individually in groups. And here what you see is like we have the pink color, we have the green color, we have the yellow, we have the orange, and we have the red color. And we already looked at the face of those different pieces. And you can see that IVC diameter is one of them, EPSS, CRT, change in mitral diastolic E wave, change in the aortic blood flow, and so forth. So I need actually to organize this in a better way. So let's just start looking at this and see what tools do you have in your ICU. So to scan this, I'm not sure if it's going to work because it should actually start giving me something. But if you scan it and start writing whatever tools you have in your ICU, I think you can put up to 6 different methods of assessment of hemodynamics. So let's see if we can get something here. Okay, we started getting something, so it is working. So please write anything, whatever comes to your mind. Some people say that still using pulmonary catheterization, Swan-Ganz, cardiac output monitoring, focus, flow track. Excellent. So we have a total of 40 participants. We have 10 answers, focus, auto saturation, IVC, EV1000, perfect. 2D echo machine, ABGs, CVP, IVC, CVP, perfect. We have a total of 26 different answers. We have here mixed venous. Appreciate your input. Thank you very much. Let's move. And let's try to organize things. So I just put the formula that we're going to work with in a different, in a nicer way, actually, for presentation. And I added something. So we start with assessment of perfusion. So I need to assess the tissue perfusion. And this is the purpose of the blood pressure. So the difference between the arterial and the venous side, which is the blood pressure that we're working with, equals stroke volume multiplied by heart rate, multiplied by systemic vascular resistance. And stroke volume is the components of preload, contractility, and afterload. And you can see here that I actually put a two-way arrow between systemic vascular resistance and arterial elastance. So this is afterload, but I don't want you to be confused. We're talking about central afterload here at the level of the aorta and what the heart is going to eject against. And this is systemic vascular resistance. And if we start looking at the tools that we have, I can get the blue color all together and look at what we have here. I can assess the tissue perfusion clinically by just looking at the skin, by measuring the capillary refill time, by looking at organ functions, and then I can look at the central venous saturation or mixed venous saturation. You can look at the gap in the CO2 between the artery and the venous, or the venous and the artery. And then most importantly, we can measure lactic acid. I'm not going to detail in terms of tissue perfusion. This is another lecture by itself. But I just want you to understand that this is your assessment in terms of, is this blood pressure adequate for tissue perfusion? Because shock is defined as hypotensive patient plus evidence of tissue perfusion. And then we go to those specific elements. Start with the preload. Are we going to measure the pressure? So that could be with a CVP, with a pulmonary capillary wedge pressure, or even we can do the capital E to E prime ratio. Or are we going to go with the volume and measure the end diastolic volume, or measure the IVC diameter as a reflection of the preload? Then we have contractility, and that can be measured by just looking at the echo and estimating the ejection fraction. We can measure the EPSS, or we can measure the MAPC also. That gives us an idea about the contractility of the heart. And then if we have this idea about the contractility and the preload, we can measure the stroke volume. So the stroke volume is the combination of these three factors together. We can measure stroke volume through VTI multiplied by cross-sectional area of the aortic valve. And we can use thermodilution method or pulse contour analysis to measure the cardiac output or the stroke volume. So with the thermodilution, we can measure directly the cardiac output. With a pulse contour analysis, we can measure the stroke volume. Once you multiply this with a heart rate, you get the cardiac output. And then you have some maneuvers to do in order to see whether patient is fluid responsive or not. And those maneuvers would be changing in the intrathoracic pressure, number one. Number two, changing in the position of the patient, whether you elevate the legs or you elevate the head of the body. And the old way is to give fluid bolus. We try to avoid giving fluid bolus. Once you give it, you cannot retract it if the patient is not making urine and cannot tolerate diuresis. And that's why it's very important to understand those maneuvers, changing in the intrathoracic pressure. How is it going to be reflected on the stroke volume? And in order to do this, we can actually measure the changes in the PTI. We can measure the pulse pressure variation, stroke volume variation based on those maneuvers. We can measure the change in the blood flow, the aortic blood flow, or change in the IVC diameter itself, or even look at the pulse oximeter. And of course, you can look at the mitral early diastolic wave of the valve. So this way we can assess fluid responsiveness. And then we can get even more information from the arterial waveform of the blood pressure. And we can also look at systolic blood pressure variation with these maneuvers that we have. And once we get this, actually, if we get all those elements, it would be easy to calculate the stroke volume. But you can look at the stroke volume also by looking at the pulse contour analysis and by looking at the arterial waveform. And you can do the echocardiogram. If everything else is normal, cardiac output is elevated, at that time it is systemic vascular resistance problem. So you can see how we organize things in a way that I understand which tool is going to give me which information I want to put it in this formula and make sense of the formula where I can actually assess why my patient is hypotensive. What am I dealing with? Is it one problem only, or is it a combination of issues together? So with this introduction, of course, I wanted to just like not to forget that we need also to put in our mind the central afterload, the arterial elastance, which is end systolic pressure divided by stroke volume. It would be also equivalent to the heart rate multiplied by resistance. So you understand, if you have a patient with tachycardia, the blood pressure is going to be elevated. Now with this, let's just try to answer this question. Which of the following tools do you prefer to use when assessing hemodynamics in critically ill patients? Do you prefer to use invasive methods with like Swan-Ganz catheterization? You use pulse contour analysis devices or any other semi-invasive tools? Do you use echocardiography, or do you use just clinical assessment without any other tool? I just want to correct something I said in the previous slide. You know, if the patient's heart rate is elevated, the arterial elastance is elevated. Okay. So I think, you know, with this, I'm very pleased with the answers here, because this is my aim, that you get so much information out of echocardiography and ultrasound. And now I use the same actually platform, I use the same pieces, but I want to select which ones we can do with echocardiography. And take a look on this. If we eliminate the ones that require more invasive methods, you will see with echocardiography and ultrasound, I'm able to assess the preload, I'm able to assess the stroke volume, contractility, I'm able to assess fluid responsiveness, and get an idea about systemic vascular resistance. So much information can be obtained if you are able to do if you have the ultrasound machine, of course, and you are able to determine those different components based on this. And I want actually to say that for those who are working with mechanical device, you're probably more familiar with the PV loop. And this is like any other pressure to volume relationship. We're relating the pressure in the left ventricle compared to the volume in the left ventricle. And you can see here, we can start from any point here, but let's just start from the point of filling the left ventricle. We start from end systolic volume, and then we fill the left ventricle, so the pressure goes up gradually. And we get a curve. This curve is called end diastolic pressure volume relationship. At one point here, we start contracting, and the first phase is isovolumic contraction before we eject any blood out of the ventricle. And then the ventricle has to face the afterload. So those would be the afterload markers, and eject the blood out of the left ventricle. So we get the systolic blood pressure and the diastolic blood pressure here. Of course, this is where the aortic valve opens, and this is where the aortic valve closes. The difference between systolic blood pressure and diastolic is the pulse pressure. And then the point here at the end of systole is the end systolic pressure. And then we start with isovolumic relaxation, and the cycle goes again and again. As you see, we have three curves here. We already mentioned the first curve here. And then we have a line that is called the arterial elastance line. And I'm not going to go into the details how we obtain this line, but it goes from the end systolic pressure into the end diastolic volume. And this is the formula for it that I mentioned in the previous slide. End systolic pressure divided by the stroke volume is the arterial elastance, which equates also the heart rate multiplied by resistance. And the last curve, or the line that we have, is the contractility line, or end systolic pressure volume relationship. And this gives me an idea about the contractility of the heart. And here is actually, if you want to replot everything I've said, you can see that this CVB and the pulmonary capillary wedge pressure and the E to E prime will give you an idea about the pressure. And here we can actually get idea about the volume, the IVC diameter, and the diastolic volume and change in the IVC. And when I actually do those maneuvers, or before we do maneuvers, actually when I measure the stroke volume, I can measure it with the VTI, with the pulse contour analysis, or I can measure the cardiac output with the thermodilution. So we can get a measurement of this stroke volume here, which is the shaded or the blue area, the light blue area. And I can actually get an idea about the contractility by EPSS, the MAPC, and the ejection fraction, or looking just at the heart contractility by the naked eye. And the last thing is actually the thing before the last, we can assess responsiveness, as we said, with different methods, and we can assess the blood pressure by the arterial waveform and the systolic pressure, blood pressure variation. And finally, we can assess the elastance and the systemic vascular resistance by pulse contour analysis, arterial waveform, and echocardiography. So you can simplify this PV loop in the heart in boxes, actually. So you can see this is the original one. Let's just take off this area here and add these two areas here. So if you actually take off this area, add this to the bottom of the box, we can actually simulate most of what we do in boxes rather than just like do the loop itself. And let's just look at different scenarios. And this is the normal heart. We can actually have patient with increased contractility where the stroke volume ejection fraction is going to be increased. This is hyperdynamic heart. Or we can have decreased contractility where the stroke volume ejection fractions decreased, and we have an increase in end diastolic pressure if the heart is unable to contract and get the blood out of the left ventricle. This is going to move the contractility line to the right. We also can have an increased arterial elastance. The afterload is increased on the heart, or on the other hand, we have a decreased in arterial elastance. And you can see the changes in the box, how they are affected by changing this volume. In fact, actually, you can play with it right and left. Just move any of those lines, you will see how is that going to affect the end diastolic volume, the end systolic volume, the stroke volume, and other parameters. And then patient can have increased preload or decreased preload, and that's going to affect the loop in a different way. So let's just start our assessment. The first thing we need to assess is the preload. And what do we have in terms of the preload? We can measure the pressure, or we can measure the volume. So if I ask the question, among the options below, which measure is the preferred indicator of preload at the bedside in critically ill adults? Do you prefer to use the pressure measurement like CVP, pulmonary capillary wedge pressure, or even the early diastolic wave ratio to the E prime? Or you use volumetric measures, and of course those are static measures, or neither one. And let's see, we have only 10 votes so far. Let's just give it 30 seconds. I think we're doing fine in terms of time so far. Okay. So I'm glad to see that so far 45% of you said neither. Okay. And that's why, because preload is actually defined as the left ventricle or the right ventricle wall stress at end of diastole. And that is actually given with this formula. I'm not going to go through this formula, but let's just play it out. This is the end diastolic curve, and let's just fill the ventricle, the left ventricle, with blood. As we fill it in, the pressure goes up. So we have more volume on the x-axis, and we have more pressure on the y-axis. And then, as you see here, we get to an area where we have a curve going up faster. And this is the end diastolic pressure volume relationship curve. And it is actually related to the compliance or the elastance of the ventricle. You can see we have one part here that can read a different elastance or compliance compared to the other part here. Okay, so do we know the compliance or the elastance of our patients when they come to the ICU? Do we know if they have diastolic dysfunction or not? So let's take a look on another patient. What if your patient's compliance is actually with a light blue curve? So if we measure the volume here, look at this. The same volume is actually going to give me two different pressures. So is this going to be, am I going to use the end diastolic pressure to estimate preload? Or am I going to use the end diastolic volume to estimate the preload? Without knowing the compliance, it won't be actually very accurate. And that's why the majority of people stopped using the CVP as a measure for the preload. And you can see here multiple trials or multiple studies, surveys actually indicated that intensivists are not using the CVP as an indicator for preload. And you can actually get fancier and measure the E to E prime. I'm not sure if it was actually studied very well in terms of assessment of fluid in the intensive care unit, because it's not an easy way to measure it. You need to use a tissue Doppler in addition to the flow Doppler, and you need to relate to these two parameters together. And we're talking about the early diastolic wave. And if it is more than 14, that means an elevated LAP. If it is less than 8, it is normal LAP. It doesn't give you much information in terms of whether the patient needs fluid or not. So in terms of whether we use this static measurements, and in the study that was actually combining all those small trials together, it showed that using the CVP is like flipping the coin. It's only accurate in 50% of the time, so it does not tell me much. And what about the volume? Can we use the volume? You can actually measure the end diastolic volume easily, and you can do the thermodilution method through PICO devices to measure the end diastolic volume, and that's what we call global end diastolic volume. It's a fancier way to do it, and most of you are actually doing that. I know that this device exists in multiple hospitals in Saudi and around the Middle East, and you can get different parameters in addition to JEDI, but again, the JEDI or the global end diastolic volume indicating accuracy in around 50% of the time. So it is like flipping the coin again. And in terms of also volume, you can look at the IVC. The IVC is just like pouring into the right atrium, and you can look at it easily by echocardiography. And let's have this question, which of the following IVC diameter cutoffs would suggest volume depletion? Is it less than 1 centimeter, less than 1.5, less than 2, or less than 2.5 centimeter? Okay, so I have 40% of people saying that less than 2 centimeters. And we have the remaining would say less than 1.5 or less than 1 centimeter. I want to make this statement. These methods work better in extreme situations. When it is less than 1.5 centimeter in diameter. And actually, this is a study that correlated IVC diameter with CVP. But we know that CVP is not a very accurate way, so I'm not going to put any emphasis on this study. More a study or multiple studies, actually, I'm just putting one of them, where they looked at the IVC, is it fat or flat? And if the IVC was flat, and they defined it in terms of the ratio between the two diameters of the IVC. We don't do it this way, we just measure it. But the IVC, if it is flat, it was associated with increased risk of shock by 3 times. And you can see the p-value here. And as I said, it works better in extreme situations. If it is less than 1 centimeter in multiple trauma studies, it showed a very high likelihood of hemorrhage. If it is less than 1.5 centimeter, it suggests volume depletion. But any number other than this is going to give you mixed results. It may not indicate the volume status of the patient. And the reason being, many factors can affect the diameter of the IVC. By the way, I'm going to leave the slides with the committee, so you can actually, they decide how they can distribute those slides. But you can look how detailed this slide is in terms of the different factors affecting the IVC diameter. And that's why it is not very good way to assess volume status unless it is either less than 1.5 centimeter for patients with volume depletion, or more than 2.5 centimeter for patients with fluid overload. So we're done with the first assessment, which is preload. And we know that there is no good way to evaluate preload, actually. We can get ideas, but they're not actually very accurate in determining preload. What about the contractility? Just let's have an idea how well the heart is contracting. So let's get kind of response on this video. So you have this patient, you put that echo. By the way, it's so easy to get those images. Train yourself, spend time. I know the tricky part will be to get the windows. Once you're familiar with it, it will be so easy and you get so much information. They can help you manage your patients in a better way in the middle of the night. You don't have to call the cardiologist. You don't have to call the cardiothoracic and yell at you. And all you can put the ultrasound and make determination of what's going on with the patient. So is this mild dysfunction? Is this moderate? Or is this severe dysfunction? Now, look at the heart, how is it contracting, and see how the left ventricle is actually decreasing in size. I have so far 8 votes, and you can see the results on the screen too. 13 votes, and most of you are agreeing that it's severe. Actually, this is the tricky part. Is it moderate or severe? Well, you can see here, this is actually when you train your eye very well, you can determine that this is severe dysfunction. And you can take a look on the cavity here. Is it moving? It's like nothing. Take a look on the anterior leaflet of the mitral valve. Look at the movement. If you estimate the EPSS that we'll talk about it, you will see how big it is. This is a severe dysfunction. And this is a patient that I would be worried about giving more fluid. Am I going to put the patient in pulmonary edema or not? But in terms of the definition of the LV function, the hyperdynamic is ejection fraction more than 70%. And I want you to differentiate ejection fraction from stroke volume. You can actually, the example that I use is if you have $1,000 in your bank and your ejection fraction is 70%, you can spend $700 per month. And this is a lot dependent on how much money you have. But it's much more if you have $100,000 and you spend 70% of that money, you end up spending $70,000 out of that money. So the ejection fraction is the relationship of stroke volume to end diastolic pressure. If you empty the ventricle, at that time you actually have a high ejection fraction. So hyperdynamic is ejection fraction more than 70%, and you know normal, moderate, and severely depressed would be defined according to the figures that you see on the slide. You can actually look at the myocardial excursion, and I want to give a credit for those some of those slides that I have that I took from Dr. Ibrahim Salnouri without his permission, but I thought he's going to be attending the lecture with us. So this couple of slides with these videos are from his lecture that he gave in Damascus. You can see this is the video that I presented, low squeezing effort on the left side and normal squeezing effort on the right side. You can actually, and this is actually another, I think this is the same. This is a normal function, and this is severely depressed function. Compare this to this video here. You can see the kissing sign. See how the ventricles with contraction, with systole, they are actually touching each other. That means trying to empty as much as possible from the left ventricle and diastolic volume. So this is a hyperdynamic state with ejection fraction of more than 70%. And you can actually be fancier again and measure the end diastolic volume and measure the end systolic volume, relate them to each other. You can see how it's calculated here at ejection fraction of 57%. So in addition to that, you can look at the LV fractional shortening, and it's so easy to do this. Just put an M mode at the papillary muscle level of the short axis echo, and just look at the diastole versus systole. Measure this distance, relate this distance to the left ventricle and diastolic diameter. You get a LV fractional shortening. On average, should be 1/3, 35% in terms of the contraction, the ratio. So the contraction, the difference between the end systolic diameter and end diastolic diameter should be 35% less. And the most actually, this is what I use the most, which gives you very accurate determination of the LV function, is the anterior leaflet of the mitral valve touching on the septum or not. It should touch, and if you notice here, it goes all the way and touches on the septum. If not, just put an M mode and you can actually measure this distance here. If it is less than 0.7 or 7 millimeter, it is normal. 7 to 17 millimeter, it's moderate dysfunction. More than 17 millimeters is severe dysfunction. And this is how you do the M mode. Just make sure that you're at the tip of the mitral valve when you do the M mode, and then you can look at the mitral valve. This is early diastole. This is opening of the mitral valve, and you measure the distance between the septum here and the tip of that early diastolic wave. This is what we call early point systolic. What's the other word? Septal separation. Early diastole point septal separation, or EPSS. Very easy to do. And then we assess stroke volume and cardiac output. Again, what we assess so far is preload, and we assess the contractility. Stroke volume is the combination between the preload, contractility, of course, the afterload also, but we can either measure the stroke volume or measure the cardiac output. Stroke volume multiplied by the heart rate is the cardiac output. And we have different methods to do this. It could be pulse contour analysis, thermodilution, or VTI. And this is the pulse contour or the thermodilution method. This is similar to any cold dilution method also that we use with measurement of cardiac output in Swan-Ganz. The area under the curve represents the cardiac output. The higher the area under the curve, the lower the cardiac output. And that is based on the Stewart or the modified Stewart-Hamilton algorithm that can actually give you the measurement of the cardiac output based on this. But you can look at the pulse contour analysis, and so much information can be actually obtained from this. And this is what those flow tracks and other machines do for you. They can look at how fast the first increase in the pressure. This is contractility. What's the area under the curve? In the systole, this is stroke volume. How fast does the pressure go down after reaching the peak is aortic compliance. And then how fast the pressure goes down after closure of the aortic valve, and how low does it go is the vascular tone and the systemic vascular resistance. And you can measure the cardiac output based on this complicated formula that we do not have time to explain it, but you have the slides and you can look through it. And also there are actually some notes in the notes section for those slides. And when they compare the thermodilution method with the volumetric pressure or with the pulse contour analysis method, they found that the results are similar in terms of cardiac output and measurement. There's easier way without needing for arterial line is if you get used to how you measure the VTI by echocardiography. And it seems to be complicated at first, but believe me, it gets easier. The tricky part is to get a very good apical view of 5 chambers. If you get that, you can put the pulse wave Doppler at the LVOT, and you can measure the velocity of the flow. And with the parasternal long axis, you can easily measure the diameter of the aortic valve. And by measuring the diameter, you can measure the cross-sectional area of the valve. You multiply this by the VTI. Of course, the VTI is a velocity time integral. So you're looking at the area under the curve here. And this is VTI. This is one section. So multiply it with the cross area. So multiply the two together, you get stroke volume. Multiply this with the heart rate, you get the cardiac output. And this is the parasternal long axis. You can measure the aortic valve just below the aortic valve annulus, and this is the LVOT diameter. I said the aortic valve, the LVOT diameter, just below the aortic valve. And of course, don't forget that this is a formula. When you measure it, you need to divide by 2 because you're looking at the radius, multiply it with a pi, and square that, you get the cross-sectional area. On the right side here is the velocity at the LVOT, and the machine will measure this for you easily if you trace it nicely, and most of the newer machine can actually help you with the tracing very nicely. When you combine them together, you get stroke volume. And this is the measurement of, I thought it is on the slide here, I don't see it, but this is the measurement of the LVOT, and you combine this with the LVOT velocity or VTI of the LVOT. You can see here that you're getting the mean, and the LVOT VTI is 21 centimeter. Normal is between 16 or 18, I believe, forgot, 18 to 22, 24. So around 20, this is what I keep remembering. Around 20 is normal, and then multiply this with the cross-sectional area, you get the cardiac output. And this is how you get the cross-sectional area, multiplied by the VTI, you get the stroke volume, multiplied by heart rate, you get the cardiac output. Very easy way of doing it. Of course, you can determine if you have a VTI of 8 centimeter. And by the way, just like think about VTI is if you put in an A line and you put the needle, and if you did not actually plug the tip of the or the other end of the needle, you can see how the blood will actually flow towards you, and the distance that the blood will actually travel by centimeter is the velocity. And actually, the VTI is the area in under the curve. So the velocity could be up actually to 90 centimeter per second. And this you can see the blood can eject all the way up to 90 centimeter per second if you open an artery. If that VTI is actually less than 16, patient has low cardiac output. As I said, around 20 is normal. You can see here a VTI of 40, patient with hyperdynamic and septic shock. And then the most important thing is this fluid responsive or not? Okay. And this is what I want to find out now. If I actually do any of those maneuvers, do I change the stroke volume or not? Well, the maneuvers would be either to give a bolus or do auto-transfusion or change intrathoracic pressure. And I can actually measure VTI, I can measure stroke volume, I can measure pulse pressure, I can measure aortic blood flow or IVC diameter. Or you can actually measure the auto-saturation or the early mitral valve, early wave of mitral valve in diastole. Again, another question for you here. Based on these ultrasound echo findings, what would you do next? Would you give fluid bolus? Would you start norepinephrine, start dopamine, or perform other assessment methods? Somebody already determined that this patient, based on the hyperdynamic state of the heart, look at the collapsibility here. 3 of you determined that they are confident and actually given fluid without doing any other methods, which I agree with. But if you want to do LVOT for this patient, you can see the variation in the VTI. If you want to do a VTI for this patient, you can see the variation between inspiration and expiration, and you can actually determine that you need to give this patient volume. And the idea of all those fluid responsiveness comes from Frank-Starling curve. It's very easy actually to understand. Of course, I do not know the curve of my patient, but let's just imagine that this is my patient. And if I want to know whether my patient resides here or here, I need to move in between 2 points. So the first point, I need to move preload, and this is Frank Starling again, stroke volume plotted against preload. I need to increase the preload, and I need to measure the stroke volume. Is this increased preload is associated with a significant increase in the stroke volume? How do I change the preload? I can give a bolus, I can change intrathoracic pressure, or I can change the position of the patient, whether passive leg raising or upper body elevation. And then I measure the stroke volume. So on the other side here, I look at either the stroke volume variation or any other parameter that actually give me an indication that the stroke volume has changed, like pulse pressure variation, aortic blood flow variation, VTI variation, stroke, systolic blood pressure variation, or change in the IVC. And you can do this with counter pulse with the pulse contact analysis, and you can see here how the stroke volume. You can see it with your own eyes actually. If you have an A line, you can see that there's difference in the stroke volume, in the pulse pressure, in the systolic blood pressure between this area here and this area, and the same thing for the pulse pressure here. And those are the maneuvers: respiratory variation and expiratory occlusion, passive leg raising, upper body elevation. You can give rapid fluid challenge, you can give mini fluid challenge, it doesn't matter. What you notice is with changes in the respiratory cycles, you can see here that we have blood pressure variation. And if you hold that respiration, you eliminate this blood pressure. This is known since the 80s actually. And this is the principle of all those changes. The more changes in the pressure, whether it is positive pressure or negative pressure, the more variation you're going to get. And this is the principle of IVC collapsibility. You can look at the collapsibility and relate it to the CVP, and you can come up with an estimate of the, you can look at the collapsibility and the IVC diameter and get an estimate of the central venous pressure. And you can look at the distensibility index, the IVC maximum minus minimum divided by the maximum. In patients on the ventilator, if that ratio is more than 18%, that means patients may respond to fluid. If it is less than 18%, you can see the variation here very easily. The patient is not fluid responsive. In patients who are not ventilated, 50% is the cutoff. Let's just hold expiration. If you hold expiration on the ventilator, you're decreasing the intrathoracic pressure. What does that do for the venous return? It goes up and it will increase the cardiac output. If that increased by 50%, this is an indication that the patient needs fluid. Let's elevate the lower extremities. If you elevate the lower extremities, you can mobilize around probably 400 ml of blood. Just let's keep this for 60 seconds or 90 seconds at 30 or 45 degrees. And notice, do we have a change in the aortic blood flow? Do we have a change in the stroke volumes, change in the pulse pressure, or change in the end tidal CO2, and change in the blood pressure? Easy way for resource limited settings: look at the blood pressure, elevate the legs for 90 seconds and measure the blood pressure before and after. If there's more than 10%, this is a fluid responsive patient, give him a bolus. If you have other fancier ways to measure stroke volume, pulse pressure, do it. And the other thing is, if it is very embarrassing for the patient to elevate the legs, elevate the upper body. You can see that this study actually looking at the VTI assessment in terms of the upper body, because you can do the same thing between flat and 60 degrees. And you can see that here VTI changes. And as I mentioned before, VTI is very easy to do. The normal here is 18 to 22, just like emphasized, is not 16. 18 to 22, as I said, is around 20. That's what I look for. And if there's if there's increase more than 12%, that is a state of fluid responsiveness. Patient can benefit from fluid. And you can also look at the SpO2 here. You can look at the SpO2, you can look at the blood pressure, and you can look at variation with inspiration, inspiration and expiration. The blood flow changes with inspiration, expiration, and you can see this on the pulse oximetry, and that's what we call pulse oximetry plethysmography. Any changes in this more than a certain percentage will give you an indication that your patient is fluid responsive. And people looked also at the early wave diastole and how is it changing. But in that study, it was actually negative study. It doesn't help, and I don't do it routinely. And those are the parameters. This is I just like use this study. This is the same study from Paul Marek that combined all those smaller studies together to give us an area under the curve for the threshold for where we can say that the patient is fluid responsive or not. And you probably notice here that the higher AUC, the better the test. And most of those tests are similar, whether you're using PPV or end occlusion test or aortic blood flow, but also acceptable results from systolic blood pressure variation, stroke volume variation. The IVC and mechanical ventilation performs better. We're talking about variation than in spontaneously breathing patient. So, and of course, in this one, it's included also the CPP variation. However, static test, whether it is pressure or volume, did not result into significant numbers. And the final thing, if we're done with all this, actually, if you know your stroke volume, you know your heart rate based on the preload contractility and elastance, and you know your blood pressure, of course, you can calculate the stroke, the systemic vascular resistance. But you can look at it from the pulse contour analysis, and you can look at it from the wave form analysis by seeing how deeply, how quickly the deceleration of the pressure wave after closure of the aortic valve. And the diastolic blood pressure on the blood pressure measurement is a good indicator for the low SVR for the patient. On the echocardiography, if everything is normal, you have a high cardiac output, that is associated with a low stroke volume. This way, we can actually, if we put all those parameters together, we can look at the full picture and you can make a diagnosis of your undifferentiated shock and help your patient in a better way. Thank you very much. It took me 55 minutes or 53 minutes exactly to go through all those slides. I know it's heavy, but I hope it gives you a better way to look at assessment of hemodynamics.
Thank you very much, Dr. Mazen, for this outstanding talk. Really, you didn't only take us through a journey, you took us through a story. And, you know, you're a very good storyteller. And I have to say, I really enjoyed the journey you took us through. You know, the capability to disseminate knowledge is not something that everybody obtains and are able to do. And I have to really take a minute just to applaud you on how you simplified one of the very complex areas in hemodynamic monitoring. To start off, while the questions are coming in, I want to ask you a question with regards to the decision to use specific hemodynamic monitoring parameters, because as you clearly, eloquently mentioned, use whatever tool is available for you and also familiarize yourself with the resources available for you. So for example, if you don't have a SWAN GANS, that does not mean that's the end of your assessment of your patient. Something as simple as a passive leg raise test can really give you a lot of information if you don't have an echo. So adding to that question, my question to you is, at what point would you reach out for a SWAN GANS based on your experience?
Oh, thank you very much for restating how much information we can get out of our clinical examination. In a patient with warm extremities, in shock, with a blood pressure of 70/28, this is a low SVR. Pulse pressure is elevated. This is a low SVR syndrome. There are only two conditions can cause low SVR: neurogenic shock or distributive shock. In a patient with cold, clammy extremities, narrow pulse pressure, 80/50, this is cardiogenic, hypovolemic, obstructive shock. Now, we rarely need to advance in our methods and escalate to the level of pulmonary artery catheterization. You can get so much information from other non-invasive methods, such as echocardiography or semi-invasive methods, if you have the pulse contour analysis methods. However, if things are not going the way expected, you have an ARDS patient in shock and going into renal failure, and you really need to be more accurate, and you're not confident with the information that you're obtaining from all the other methods at that time with the Swan-Ganz. And by the way, the study that showed Swan-Ganz is not associated with difference in outcome, it's actually been re-challenged. And probably we're not reading Swan-Ganz the right way. We probably can do better if we understand hemodynamics, if we understand the numbers better, and we act on those numbers better. It may give us better results. So this has been studied in actually smaller cohort of patients that had Swan-Ganz interpretation by an intensivist at a higher level. And it showed that it can help. So it may actually be coming back. Yeah. But for me, you know, if the answer to your question, if I'm confident with the information I'm obtaining from other methods, I don't have to do Swan-Ganz. Otherwise, just perform Swan-Ganz and get more confident.
Appreciate that. Another question from the audience states that, you know, different type of shock can affect the shape of the Frank-Starling's curve. So the question is, how would mechanical ventilation affect your parameters? And the other question is, would a vasoplegic patient affect your measurements?
Well, to start with the vasoplegic, this is what we're trying to identify, whether my patient has a low SVR or not. So if the patient has high cardiac output, the stroke volume is elevated, you do an echocardiogram kissing sign, but also you have a preload parameters that are adequate. Contractility is good. What's the etiology of why the patient is hypotensive? It is SVR. Mm-hmm. So this is how you identify whether your patient is vasoplegic or not. So that's for the second part of the question. The first part of the question, you know, what affects Frank-Starling is the compliance of the ventricle. So do I know if my patient is having Frank-Starling flatter than normal? So is my patient having cardiomyopathy that I'm not aware of? Because, you know, I see the patient in the middle of the night, no record available, no history. I put the echo and I see that stroke volume changed from a certain point to another by less than 10%. Well, is he on the flatter side or the whole curve is flat? See? So he's actually low. I should have put a slide for this. I can actually add it in the next presentation, hopefully. But that shows if the curve is flatter, it's really difficult. And that's why those methods are not 100% accurate. And this is where you need probably Swan-Ganz for the patient, where you cannot identify whether your patient's fluid responsive or not, because the patient's got cardiomyopathy and the Frank-Starling curve is flatter. So you cannot identify 2 points where you say that if I increase the preload from this point to this point, stroke volume will increase.
And, you know, one of the other things we tell our trainees is when you get a specific set of numbers, you're comparing these numbers to where you were an hour ago. So yes, there are certain caveats to, for example, a vented patient. But if I'm comparing my vented patient and point A to point B, and point B is better than point A, at least that gives you a sense that you're heading in the right direction.
And that is perfect, actually. Thank you very much for adding this. Trend is very important. Just notice what's been happening to your patient. Whatever parameter you have, just trend it and see how it's moving.
We have another question from Dr. Muhsin. He's giving you a scenario of a patient who has AKI, and basically he's hemodynamically unstable. The MAP is less than 65. He appears to be third spacing, so there is severe edema, and the patient is congested. He says that they started a bolus of NS 250, and the MAP did not correct. They started norepinephrine and dobutamine, still hasn't budged. And he says the facility does not have CRRT. So what would you suggest at this point?
So first, let's make sure that the patient is intravascularly volume overloaded. And this is by itself is a lecture. And on ICU Reach, you can see a very nice presentation from Dr. Murad from University of Alabama about the congestion cascade. And you can do this with VEXAS also, and very easy, you can determine. So it is very important that you're not actually trying to remove fluid from a patient who's third spacing, but intravascularly depleted. So the question I understand is he confirmed that the patient is intravascularly volume overloaded in addition to third spacing. And if that's the case, so the answer, if you're not able to, if patient is not responding to diuresis, CRRT for someone who's hemodynamically unstable is the answer. And the question is, what if CRRT is not available? Well, it's difficult because the patient is not going to tolerate regular hemodialysis. In some places, they may do peritoneal dialysis and remove fluid through the peritoneal dialysis.
Another question is the notion of fluid tolerance and fluid responsiveness. And they're asking, are there any updates regarding this point or any areas where they can read more about this?
Yeah, so I can actually provide resources. However, tolerance, just for people who are with us here to understand what do you mean by tolerance, meaning that giving more fluid is not going to help. Okay, that is actually going to take us to fluid overload. And actually, everything we've said, giving more fluid is not going to help, meaning that we're on the right side of Frank-Starling curve. So that means we did not increase the stroke volume by more than 10 or 12%. We did not increase the pulse pressure by more than that certain value. Same thing for the IVC diameter. So it all falls in the same actually type of presentation that we went through.
And the second question also follows the same as the question we talked about, is basically fluid responsiveness versus fluid tolerance. Another question tells you, what are the limitations for PPV, VTI, and IVC measurements? We've already tackled this question earlier.
But also you need to change, it actually depends on the method that you're using to increase that or change that preload. So someone who's on 4 ml per kg of the tidal volume is not going to make that changes in the intrathoracic pressure. You need to have a good tidal volume, and in the literature they say 8 ml per kg. And you can do that for short time for protective lung strategy actually, and just measure and go back to the 6 ml or less. So you need to have, just understand the concept. You need to have that variation in the preload. And if you're using the intrathoracic pressure, it has to be good change in the intrathoracic pressure. If you're using the upper body or the lower body position, it has to be good mobilization of volume. And of course, if you're giving fluid bolus, the fluid bolus should be enough to reflect changes in the stroke volume.
The other comment is essentially what you started off in your talk, mentioning how powerful echocardiography can be in a critical care unit in the setting of, undifferentiated shock. Gives you quick answers, it's cheap and it's available and reliable, and it's an excellent rule out in the beginning of the resuscitation. The other question is, in the...
And I just want to say in that regard, actually, please gain experience in performing echocardiography and ultrasound. You don't have to be certified by them. Just like start by practicing. You're not hurting your patients. Do not make major decisions based on your interpretation when you're early in the learning process. You'll become very confident. Once you're confident, I think you need to seek for certification, and then you can make decisions based on what you see. And I believe that every intensivist should be confident in doing the ultrasound echocardiography and interpreting this for the sake of quick management in the middle of the night. Or anytime, of course.
Dr. Mazen, the other question is, in the case of increased intrathoracic pressure, as in ventilated patients, do you measure IVC collapsibility or distendability?
Yeah, so if you're on the ventilator, we call it distensibility, because when you give the inhalation, the venous return is decreased, the IVC extends, so distensibility. If the patient is spontaneously breathing, inhalation decreases intrathoracic pressure, venous return goes up, it collapses. It is called collapsibility. By the way, it doesn't matter. You know, don't look what's like, is the patient is exhalation or inhalation, just difference, maximum diameter and minimum diameter. Don't pay attention. It's like, is this inspiration or this is expiration? Just the number is different. 18% for patients on the ventilator, 50% for patients who are spontaneously breathing.
Fantastic. 3 more to go. From Dr. Hasib, echocardiography gives a lot of information about fluid status, but when the heart reaches a stage of septic cardiomyopathy, it becomes misleading rather than false. Can we still get information in this stage?
So sepsis now is not as we used to look at as this is a low SVR syndrome. There are different stages and different phenotypes of sepsis can give you mixed parameters. And this is what I'm not sure if this is Dr. Abdel Hasib from Syria who's asking this question, but this is excellent question that you need to address. And this is where you need to apply it to the formula and see what other parameters are changed at the same time. You may have a patient with cardiomyopathy because of sepsis and low SVR because of sepsis. Combining these two together requires you to pay attention to every single, and of course, you can have also a patient who's hypovolemic. So a combination of everything together in septic patients. And this is the worst phenotype of septic patients. Again, applying the different methods that we have in our hands to look at those parameters in that way is going to help you to select the most appropriate intervention for that patient. And of course, in the scenario he's saying, the most appropriate would be vasoconstrictor agents.
So that takes me to the question.
And probably inotropic support with dobutamine.
So that takes me to the other question after the current question, because you just tackled a state of low SVR. So the other question is basically, what is the best approach to tackle a patient with high SVR in a shock state?
So high SVR, meaning that my problem is either in hypovolemia, cardiogenic, or obstructive. So we can easily rule out obstructive shock because there are very limited differential diagnosis, tamponade, pneumothorax, pulmonary embolism. If we rule out those, it's either contractility or hypovolemia. Look at the contractility of the heart by the echo. Look at the SPSS. Measure the stroke volume if you have the ability to do it, and then measure the preload. This way, you can. It could be contractility and preload at the same time also. So apply this individually, and I usually start from the preload. I like to assess first preload, fluid responsiveness, and at the same time, get the contractility, the stroke volume, cardiac output, and end with systemic vascular resistance.
We're going to answer the last question shortly. We're almost close on time. It says if you have a CKD patient with septic shock who is already on noradrenaline with no improvement in blood pressure, how do you approach it? So basically, I think what they're trying to say is septic shock, bad kidney function, they're not peeing, and you raised their MAP.
Very good. So they are not improving in terms of perfusion or in terms of blood pressure. So again, my goal is to improve perfusion. So in septic shock patient, and that's why we emphasize the 1 hour bundle, measure lactic acid and re-measure lactic acid. Make sure that your resuscitative measures are actually improving perfusion. So the goal here is perfusion. So you're telling me that this patient is, despite that he's on Levophed, blood pressure is not improved and perfusion is not improving. And of course, I would assume that the Levophed already is above 0.2 microgram per kg, so vasopressin should be on. And for that septic patient, I assume also that hydrocortisone was already started for that patient, because he reached a point where he's not responding to vasopressors. The question is, do we need to give him more volume or not? Okay. So that's where you need to use all your tools. It's like, do I need to give more volume, or this patient is already volume tolerant? And if you reach the point that, well, patient is volume tolerant, blood pressure is not improving, you're increasing, of course, some vasopressors. You can go up on the norepinephrine, 1 mic per kg per minute, or even 1.5. You're already on vasopressin. You can add epinephrine, also 3 pressors. And of course, some of those patients are not going to do well, no matter what you do. And at that time, well, it is time to talk with the family. When you start having multi-organ system failure, and those are the systems are failing, this is where I would say, well, my maneuvers are not helping. You know, I may go up on the vasopressors as long as I don't have end organ failure that are actually worsening. Because the study showing that, and Dr. Hassan Hawa presented this in Damascus, actually, the study showed that, you know, the higher dosages of vasopressors along with higher SOFA score is associated with worse outcome compared to patients on high dose vasopressors with no high SOFA scores, or actually no increasing SOFA scores.
Well, Dr. Mazen, I again want to thank you for answering these questions and taking the time. There are a lot of questions, but we're short on time, but a lot of questions means an excellent lecture. So I'm going to give it back to Dr. Ashwag.
Thank you, Dr. Mazen, for joining us today and for your excellent talk. Thank you all, the panelists. And for the audience, thank you for attending, and we hope we can see you in our upcoming webinar. And we look forward to having you in our fellowship. Feel free to reach out through our official channel, and feel free to join us in our WhatsApp group just to learn together in this journey. Thank you, everyone, for your time, and wish you a good day.